What does a heart attack actually feel like? Most people over 60 will give you the same answer: crushing chest pain, arm going numb, drop to the floor, call 911. That picture is real for some people. But a study published earlier this year in the Qatar Medical Journal found that nearly 40% of all heart attacks in people over 64 present with absolutely no chest pain whatsoever. Not less, none. Which means millions of people are walking around right now misreading their own body's emergency signals as indigestion, fatigue, or getting older. If you've ever dismissed a symptom because it didn't feel like a heart attack, this video was made for you. Here's the data behind that opening number. A landmark analysis published in Circulation, led by Dr. Zhang and colleagues, established that 45% of all myocardial infarctions are completely silent. They pass through the body without triggering the warning system we've been trained to expect. And here's what makes that number genuinely alarming. A 2018 study in JAMA Cardiology, using cardiac MRI on thousands of older adults in Iceland, found that an unrecognized silent heart attack carries a 49% 10-year mortality rate, virtually identical to a recognized one. What bothers me every time I go through this data, and I've spent weeks inside it, is the implication. The body is sending signals, real physiological, measurable signals, but we've been taught to dismiss them because they don't match the Hollywood version. The people I hear from in this community describe the same pattern. Something felt off for days, maybe weeks. They waited, and that waiting is where lives are lost. The 7 signs I'm going to walk you through today are those exact signals. And I want you to pay particular attention to sign number 5, because that one starts weeks before anything else, and it's the one we rationalize away the most consistently. Let me be direct about the stakes here. If you have a silent heart attack and don't know it, your 10-year mortality risk climbs to nearly 50%, the same as if you'd had a recognized one. The difference is you never get treated. There's no stent placed, no medication adjusted, no follow-up care, because as far as the medical system is concerned, nothing happened. For women specifically, this problem is dramatically more acute. A major analysis of the National Registry of Myocardial Infarction found that 42% of women experiencing a heart attack arrive at the hospital with absolutely no chest pain, versus 30.7% of men. After menopause, the estrogen that once protected your arteries by keeping them elastic and reducing inflammation is largely gone. Your vascular system is operating without that biological buffer, which is exactly why atypical presentations are more common in women over 60 than in any other demographic group. Most standard checkups miss this completely because they're still looking for the wrong signs. So let's look at the right ones. The first signal your body sends is almost always the same and almost always ignored. Profound, unexplained fatigue, not the kind that follows a long day, the kind that settles into your bones for no clear reason. The kind where walking up a single flight of stairs feels like it took something from you. A 2003 study, led by Dr. Joan McSweeney and published in Circulation, followed women who had experienced heart attacks and asked them to recall their symptoms. Over 70% reported an unusual, crushing fatigue in the weeks, sometimes more than a month before their cardiac event. Not during, before. The mechanism is precise. When a coronary artery develops a significant narrowing even before it fully blocks blood flow to the heart muscle is compromised, the heart cells begin to run on reduced oxygen. They produce less ATP, the body's primary energy currency. To protect its most vital organs, brain, kidneys, heart, your body quietly begins pulling blood away from your skeletal muscles. Your limbs receive less oxygen. Every physical effort costs more, and your brain registers this as exhaustion. The cruel irony is that this signal arrives weeks before the crisis, meaning there's actually a window to act. But almost nobody acts, because the explanation feels obvious. I'm 65, I'm tired, that's just life. It's not just life. If you notice a sudden sustained change in your baseline energy that doesn't resolve with rest, and it's been there for more than a week, that deserves a conversation with your doctor. Sign 2 sends people to the dentist. Pain in the jaw, the throat or the neck with no chest involvement whatsoever, no toothache that explains it, no sore throat starting, just a deep dull ache that seems to come from the left side of the face or the base of the throat. Research published in the Australian Dental Journal found that the throat and neck are affected in 41.5% of cardiac-referred pain cases, and the left jaw in 28.3%. The biology behind this is one of the most fascinating convergence errors in human anatomy. The pain signals from your heart travel upward through your spinal cord, using the same neural pathways as the sensory nerves from your jaw and throat, specifically the cervical segments C1 and C2, and the upper thoracic segments. These signals merge at the same relay neurons in your spinal cord. Your brain receives a flood of input through this shared pathway, and because it has almost never processed severe cardiac pain before, it makes a spatial error. It projects the sensation outward onto the face, the jaw, the left side of the neck, as if the pain originates there. People go to their dentist, they take anti-inflammatories for a presumed jaw disorder, they wait it out, and the real cause continues silently downstream. If you develop unexplained jaw or throat discomfort, particularly on the left side, particularly at rest, that is not a dental problem until proven otherwise. Sign 3. Sudden shortness of breath at rest or from minimal effort without any obvious respiratory cause. Research shows this is actually the dominant symptom in 76.9% of atypical heart attack presentations. It's not a secondary complaint, it's the main event, and it's being misread as deconditioning, aging, or a flare of chronic lung disease. Let me show you the mechanism, because understanding it makes it unforgettable. When part of your heart muscle becomes ischemic, oxygen deprived, it loses its ability to relax properly between beats. Cardiologists call this diastolic dysfunction. The left ventricle, now stiff and inefficient, can't fill adequately. Pressure inside the chamber rises sharply. That pressure wave moves backward through the left atrium, into the pulmonary veins, and into the tiny capillaries of your lungs. Fluid begins to leak into the lung tissue. Special receptors called J receptors embedded in the alveolar walls detect this congestion instantly. They fire a signal to your brainstem, breathe faster, breathe harder. You feel a sudden, alarming shortness of breath that seems completely disproportionate to what you're doing. Walking to the kitchen, standing up from a chair, climbing 3 steps, if that sensation is new, if your breathing reserve has changed in the last few weeks without any respiratory illness to explain it, that is cardiovascular territory, not pulmonary aging. Sign 4. Sudden severe nausea. Indigestion that appeared from nowhere. Vomiting with no meal to explain it. This one sends people to urgent care for food poisoning, while the actual cause is in the chest. Over 57% of atypical heart attack presentations involve sudden nausea as a prominent sign, according to clinical research on atypical MI cohorts. The mechanism involves your vagus nerve, the 10th cranial nerve, which runs directly from your brainstem down through your chest and into your digestive tract. The posterior and inferior wall of the heart, supplied by the right coronary artery, is richly innervated by vagal sensory fibers. When ischemia hits this territory, even transiently, lactic acid and inflammatory compounds build up rapidly. These activate those vagal fibers directly. The signal travels up to the brainstem's emetic center through what's called the Basal-Jurisch reflex. The result? Sudden nausea, vomiting, sometimes eructation, belching that feels exactly like a digestive emergency. And so people take antacids, they rest, they wait. The tell with cardiac nausea is the combination. Nausea plus unusual fatigue, nausea plus a strange jaw ache, nausea plus sweating that started out of nowhere. One of these alone may be benign. 2 or more together, with no clear digestive cause, is a different situation entirely. Before I continue, let me quickly recap what we've covered. 4 signals so far. Exhaustion that arrives weeks early, jaw and throat pain that looks like a dental problem, breathlessness from minimal effort, and sudden nausea that mimics food poisoning. All of these can appear without a single moment of chest discomfort. Sign 5 is the one I hear discussed the least, and the one I think deserves the most attention because of when it arrives. Then we'll get to the climax of this video, a discovery that rewrote how cardiologists think about cardiac risk in women over 60. That revelation is in sign 7. Keep watching. Of all 7 signals on this list, sign 5 has the highest recorded prevalence, and it's the one most frequently written off by women over 60 as something hormonal: a sudden, unprovoked cold sweat, clammy skin, profuse perspiration that has nothing to do with temperature or exertion. Clinical research documents this in over 92% of atypical heart attack cases. Here's the physiology. When the heart begins to fail as a pump, even acutely, even partially, cardiac output drops. Blood pressure begins to fall. The body's pressure sensors, located in the aortic arch and carotid artery, detect this immediately and trigger a full emergency response. The adrenal glands release a surge of epinephrine and norepinephrine into the bloodstream within seconds. This catecholamine surge does 2 things simultaneously. It constricts the blood vessels near the skin surface, pulling circulation inward toward vital organs. The skin turns cold and pale. At the same time, adrenaline directly activates the eccrine sweat glands. Cold, sticky sweat emerges even as the skin feels cool. This is your body's last resort attempt to maintain blood pressure. In women over 60, this signal is particularly dangerous, not because it's different, but because it's so easily explained away. Late vasomotor symptoms, a thyroid fluctuation, the room being too warm. The experience of sweating at 60 is so normalized in women's health conversations that its sudden, new, unprovoked version goes unreported. If you experience a cold sweat that arrives from nowhere, at rest, with no clear thermoregulatory cause, particularly paired with any of the signs we've already covered, that combination is a medical emergency. Sign 6, sudden dizziness, lightheadedness, or a brief fainting episode, at rest, without standing up too fast. A 2023 study published in Curis found that syncope, actual loss of consciousness, occurs in approximately 12% of atypical heart attack presentations. Dizziness short of fainting is even more common. There are 2 pathways that produce this signal. The first is electrical. If the ischemia touches the heart's conduction system, the sinoatrial node which sets the heartbeat, or the atrioventricular node that coordinates chambers, the result is a dangerous slowing of the heart rate. Cardiac output drops instantly, cerebral perfusion falls. The cortex, deprived of blood for even a few seconds, produces the sensation of lightheadedness or triggers a syncopal episode. The second pathway is a reflex loop. The vagal reflex that drives the stomach nausea we discussed earlier can simultaneously cause peripheral blood vessels to dilate. Blood pools in the limbs. The heart slows. The combined effect, slow heart plus open vessels, creates a rapid drop in blood pressure and brain perfusion. The dangerous misread here: almost everyone over 60 on blood pressure medication attributes sudden dizziness to their medication or dehydration. They drink water, they sit down, they wait for it to pass. If dizziness is new, comes on at rest, and is accompanied by any other sign on this list, that explanation isn't sufficient. Sign 7, sudden bilateral ankle swelling. Both feet, both ankles, appearing over 1 to 3 days with no change in your lifestyle. This is a later signal than the others on this list. It tends to appear after a silent cardiac event has already occurred, as the heart's failure becomes more global. But it's critically important precisely because it is visible and measurable, and yet still consistently dismissed. Research from the Archives of Internal Medicine found that approximately 1 in 5 heart failure patients delays calling for emergency care by more than 24 hours, even when they have visible pitting edema. The mechanism involves 2 systems failing in concert. When the right side of the heart weakens, whether from a silent infarct or progressive ischemic disease, blood in the venous system backs up. Venous pressure rises in the legs. Fluid is pushed outward through the capillary walls into the surrounding tissue. Gravity pulls it downward, pooling in the ankles. Simultaneously, The kidneys detect the falling cardiac output and interpret it as hemorrhage. They activate the renin-angiotensin-aldosterone system, triggering aggressive sodium and water retention, more fluid, more swelling. This is not varicose veins. This is not a long day on your feet. Pitting edema, swelling that leaves an indent when you press a finger into it, that is new, bilateral, and accompanied by any breathing difficulty, is a cardiac sign until proven otherwise. I promised you something earlier, a finding that fundamentally changed how we understand cardiac risk in older women. This is it. For decades, a quiet medical tragedy repeated itself in hospitals across the country. Women in their 50s and 60s presenting with breathlessness, crushing fatigue, sudden sweating, would receive a coronary angiogram, the standard test for blocked arteries. The result would come back clear. No major blockage, no stent needed, and they'd be sent home, often with anxiety medication, their symptoms dismissed as psychosomatic. The NIH-funded Women's Ischemia Syndrome Evaluation, the WISE study, exposed what was actually happening. These women weren't imagining their symptoms. They had a condition called inoca ischemia with non-obstructive coronary arteries. Instead of large arterial blockages, their disease lived in the microscopic network of tiny vessels inside the heart muscle. Those vessels, normally able to dilate and increase blood flow during stress, had lost that capacity entirely. The large arteries looked open. The heart was starving at a cellular level. 20% of symptomatic women with clear coronary arteries had measurable reductions in oxygen delivery to the heart muscle, and their 10-year cardiovascular mortality tracked as high as 31%. This is why the absence of classic chest pain and a normal coronary result cannot be taken as final reassurance. Cardiac disease in older women frequently doesn't announce itself the way medicine historically expected. When I first went through the WISE data in detail, what struck me wasn't just the number, it was the word sent home. Women who came in with real symptoms, real physiology, real distress, and were told there was nothing there. Knowing what we know now, that pattern needs to change, which starts with patients and their families knowing what to look for before they even walk through a hospital door. That's what today is about. Before I send you to the next video, I want to know something specific. In the days or weeks before any cardiac event you've experienced, or that someone close to you has gone through, what was the first sign that something felt different? Not the dramatic moment, the quiet one before it. Drop the symptom, and roughly how many days before it appeared in the comments. I'm tracking patterns across this community, and what you share here genuinely shapes what I research next. 3 things worth monitoring that don't require any equipment beyond a home blood pressure cuff. First, your resting blood pressure trend. A sudden, unexplained drop, not explained by a medication change, can indicate the heart is losing its ability to generate normal output. Second, your heart rate at rest. A new bradycardia, heart rate dropping below 55 when that's not your baseline, or sudden unexplained palpitations warrant investigation, not observation. Third, your exercise tolerance. The most sensitive early marker is a sudden reduction in what you can comfortably do. If walking a familiar route now leaves you winded in a way it didn't 3 weeks ago, that's not fitness decline. That's a signal. And the rule that matters most from today, call emergency services if 2 or more of the 7 signs in this video appear together, even if your chest feels completely fine. Research suggests that seniors wait more than twice as long as younger adults to call for help because no single atypical symptom feels urgent enough. The combination rule removes the ambiguity. Everything I've shared today is for educational purposes only. Please talk to your doctor before making any changes to your health routine, and if you experience any of these symptoms suddenly, don't wait for a video to tell you what to do. Call for help immediately. Your physician is the only person qualified to evaluate your specific situation. What you learned today starts years earlier in your blood. That upstream trigger is in this video. Watch it next.